Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Will. Today's episode features Dr. Shaji Kumar and Dr. Vincent Rajkumar, both from the Mayo Clinic in Rochester, Minnesota, Dr. Thomas Martin from the University of California, San Francisco, California, Professor Philippe Moreau from the Université Hospital Hôtel Dieu in Nantes, France, and Professor Jesús San-Miguel from the Universidad de Navarra in Pamplona, Spain. These experts will be answering some of the audience questions from a recent live webinar on the contemporary clinical management of multiple myeloma. This episode is part of a larger educational program titled Accelerating Toward Curing Myeloma: Emerging Data, New Agents, and an Evolving Treatment Paradigm. For more information on Dr. Kumar, Dr. Martin, Professor Moreau, Dr. Rajkumar, and Professor San-Miguel, along with a link to the complete program, including expert commentaries and downloadable slide sets, please visit the show notes for this episode. In this episode, each expert will introduce himself and the topic he will be covering. Now let's hear what they have to say.
Hi, I'm Vincent Rajkumar, Professor of Medicine at the Mayo Clinic, and I'll be discussing how I manage smoldering multiple myeloma. Some of the common questions we get is, should we treat patients with smoldering myeloma? If so, should we treat them on clinical trial or should we treat them in regular clinical practice? If you're going to treat them in practice, would you use observation alone? Would you use lenalidomide, Len-Dex, or a myeloma-like therapy? And so it's a complex topic, but I'll try to condense it into the main questions that we face. For many years, we have not treated smoldering myeloma because there were no good treatments. There was no good risk stratification to tell who would benefit from therapy. And there was no data that early therapy was beneficial. Now, all of those three are no longer true. We have many good treatments for myeloma, many of which can be used early in the disease course. We have good risk stratification now. We have the Mayo 2220 system, which was then validated by the International Myeloma Working Group. Essentially, if patients have two of the three risk factors, which are a monoclonal protein more than 2 grams, bone marrow plasma cell percentage more than 20%, or a free light chain ratio that's more than 20. Any two of those three makes the patient with smoldering myeloma into a high-risk smoldering myeloma. And in those patients, the risk of progression is 50% at 2 years. And so we know who are the patients that we should target for early intervention. And then finally, we have data now from at least 2 randomized controlled trials that even simple treatment like Len or Len-Dex can significantly delay the time to end organ damage. And the risk reduction is in the order of 80 to 90% in these high-risk patients. So I really believe that the time to intervene in smoldering myeloma is now here, and that the main question is not whether we should observe or give Len-Dex, but rather how should we manage these patients. The current standard of care, I think, after the 2 randomized trials is to at least consider Len or Len-Dex for patients with high-risk smoldering myeloma. But what about treating them like multiple myeloma with a triplet combination? I believe that there are some people who think we should do that because there is a concern that giving a mild therapy like Len or Len-Dex may induce drug resistance. But we have not seen that in the randomized controlled trials. And we have to weigh the potential benefit of a myeloma-like therapy with the potential toxicity in an asymptomatic patient population. Therefore, we are doing a trial in the Eastern Cooperative Oncology Group comparing mild preventive therapy with Len or Len-Dex versus myeloma-like therapy with daratumumab Len-Dex. And that trial is accruing really well, and we think it will answer this question soon. Of course, you could ask the question, can we cure smoldering myeloma if you go more aggressively in the early asymptomatic stage? And that is an important question. I think that is not ready for prime time in clinical practice. but rather, if patients are interested, they could enroll on one of the trials that is testing such an aggressive approach. In the US, there is the ASCENT trial, which is using a very aggressive approach to treating these patients with the goal of seeing can we cure them. So in summary, when I see a patient with possible myeloma or smoldering myeloma, we do a full workup. If the patient has myeloma-defining events, then the answer is clear. You treat them like myeloma. If the patient has smoldering multiple myeloma, you use the 20-20 risk stratification model to classify them into low risk or high risk. You could get a better discrimination if you use the scoring system that has been published by the International Myeloma Working Group. If your patient has high-risk smoldering myeloma, then certainly consider therapy on a clinical trial. And if a clinical trial is not available, then at least lenalidomide or Lendex for about 1.5 to 2 years would be my recommendation, and that's what I do. For low-risk smoldering myeloma patients, continue to watch them every 3 to 4 months. They do have a higher risk of progression than MGUS. When we follow patients with smoldering myeloma, if you notice that they're getting focal lesions on MRI, or the M protein is increasing, or the hemoglobin is decreasing, then it's time to reassess and see if there's been early evidence of progression, and that would be an indication to change the course of management. That's it for smoldering myeloma in a nutshell.
Hi, my name is Philippe Moreau. I'm working at the University Hospital of Nantes in France. And I would like to discuss with you about the results of the Griffin study and the impact of this study for the future treatment of patients that are eligible for autologous stem cell transplantation. So the Griffin study was run in the US. It is a randomized phase 2 study comparing on more than 200 patients VRD, bortezomib, lenalidomide, and dexamethasone, both before and after stem cell transplantation, 4 induction cycles, 2 consolidation cycles, versus the same combination plus daratumumab, that is a monoclonal antibody targeting CD38. In the VRD arm of the study, patients did receive lenalidomide maintenance, and in the DARA arm of the study, patients did receive as a maintenance lenalidomide and daratumumab, and the number of cycles of maintenance was up to 32, in fact. So this study is very important because in many countries all over the world, frontline stem cell transplantation is the standard of care when patients are eligible for such a treatment. And in Europe and in many centers in the US, this is really the preferred option for patients in routine outside clinical trials up to the age of 70 years. And we know that VRD is a very effective regimen that is considered as one of the preferred options in the US. For example, the NCCN guidelines or the Mayo guidelines are recommending VRD. And in Europe as well, VRD is one of the first option, preferred option in the recent ESMO and EHA guidelines. And if we are adding daratumumab on top of VRD, the Griffin study definitely did show that we have a higher response rate after induction, after stem cell transplantation, and after consolidation as well. And the study did evaluate carefully minimal residual disease for all patients at the threshold of 10 to the minus 5 before maintenance and after consolidation. And the MRD negativity rate was much higher, increased in fact with VRD daratumumab as compared with VRD alone. It means that DARA VRD in the future will become, to my opinion, the standard of care as soon as approved. We have very good PFS with the VRD DARA, outstanding PFS. There is not yet a significant difference, but we need a longer follow-up when comparing VRD versus VRD DARA, not only for PFS, but also for overall survival. The VRD PFS and OS rates are very good, but if you are adding daratumumab on top of VRD, definitely you may improve the outcome of the patients. There is a very important study in Europe, the Perseus study, with the very similar design comparing VRD versus VRD DARA, a phase 3 study that, to my opinion, will establish VRD DARA as the standard of care for the future. We have to wait a little bit. The study was published already with a quite short follow-up in Blood in 2020. Dr. Voris, Peter Voris, was the PI of the study, and we need update analysis with a long follow-up to look carefully at the PFS assessment and OS as well.
My name is Jesús San-Miguel. I am professor of hematology, and it is my purpose to talk with you and to discuss with you about the relapse patient. And I will address three, I think, specific questions. The first one is, what is the best rescue therapy in non-lenalidomide refractory patients? I think clear should be to choose an IMiD-based therapy. And lenalidomide dexamethasone has some clear efficacy with approximately 17 months of median progression-free survival. However, this has been really overpassed with the triplets using Lendex as the backbone, together with either a monoclonal antibody, daratumumab, elotuzumab, or a proteasome inhibitor, carfilzomib or ixazomib. From this potential combination, probably the star is DARA-RD, because the progression-free survival is 44 months, and in patients in fair relapse is 53 months. This is really outstanding. And the second one is carfilzomib lenalidomide dexamethasone with a median progression-free survival of 26 months. And this combination is particularly attractive also in the high-risk patients because the median progression-free survival is almost identical for high and standard risk patients. And also there is a benefit in overall survival. The second group of patients that I want to discuss with you are more challenging, are those that are LEN refractory. And in this setting of the LEN refractory patients, the first question that we should address is how do we define LEN refractory patients? The definition can be very simple. Patients that progress under lenalidomide treatment, and it's the same if they progress under 10 milligrams or 25 milligrams, because both group of patients are really poor prognosis patients, and they represent a very large patient population. And for these patients, the obvious choice is to change the class of drug, and you can use a second-generation proteasome inhibitor, you can use monoclonal antibody, daratumumab, isatuximab, or pomalidomide, because pomalidomide is able also to rescue LEN refractory patients. The first opportunity for these patients will be carfilzomib dexamethasone that has shown to be superior to bortezomib dexamethasone, double progression-free survival, moving from 9 to 18 months. And if you add cyclophosphamide to carfilzomib dexamethasone, probably you can also improve a little the efficacy, particularly in the true LEN refractory patients. Regarding monoclonal antibodies, daratumumab has been combined with proteasome inhibitor in the LEN refractory patients with bortezomib dex. The efficacy is so-so, is around 16 months median progression-free survival, and with carfilzomib dex, the Candor study in which the median progression-free survival has not been yet achieved. Therefore, is a very interesting combination, and something very similar is with isatuximab combined with carfilzomib and dex, the KEMA study. The median progression-free survival has not been reached. However, there is a caveat in these studies, because none of them were designed really for LEN refractory patients. The proportion of LEN refractory patients was around 30% in these studies. By contrast, in the pomalidomide setting, we have the real LEN refractory population. The study, the PVD study, pomalidomide bortezomib dex, the Optimum study, has shown an efficacy, a median progression-free survival of around 11 months, and something very similar has been observed when you combine pomalidomide with monoclonal antibodies, elotuzumab, daratumumab, and isatuximab. Median progression-free survival ranges between 10 and 12 months. Therefore, these reflect that they are really refractory patients. Another possibility will be to combine pomalidomide with carfilzomib. Nevertheless, for me, if a patient is refractory to lenalidomide, the most attractive option is a monoclonal antibody plus carfilzomib, probably, and this combination, the DARA-KD, the ISA-KD, is really appealing. But unfortunately, we are going to face more and more frequently with both LEN and DARA refractory patients. What is the ideal regime? What is the ideal option for these patients? By sure, one opportunity for this patient will be to use pomalidomide and carfilzomib combined. But you may ask me, what about retreatment with daratumumab? We have not enough data to recommend that. What about the possibility of switching from dara to isatuximab? Unfortunately, we have no data. And for me, the best option will be the bispecific antibodies and the CAR-Ts, because they are targeting new antigens that has not been previously explored with the drugs, and these are the BCMA, GPRC5D, and FCRH5. These can be targeted with bispecific antibodies and also CAR-Ts. A lot of information is available and will be discussed later on. Also, we have alternative drugs such as selinexor, melflufen, and belantamab. Again, there is plenty of opportunities now for the relapse setting, and we need to be aware that our patients have new windows just to have new responses and to prolong the survival, both the progression for survival and the overall survival.
Hi there, I'm Dr. Thomas Martin from the University of California, San Francisco. And since our Friday Satellites Symposium at Virtual ASH, we've had some questions come in about, how to treat patients with these new BCMA targeted therapies. And so there were a few themes of the questions that came in. So I'm going to try to answer a few of those questions in the next 5 to 10 minutes. The first question that I'll address is, how do you choose between BCMA targeted therapies? And is there a proper sequence? So at present, belantamab mafodotin is FDA approved. And so the advantages to the BCMA ADC include being off the shelf, meaning I can start therapy tomorrow if needed, or urgently, especially for patients who may have rapid progression. It can also be given completely as an outpatient. So there's no risk of cytokine release syndrome or neurotoxicity, and it's very safe to be given in a clinical practice. It can also nicely be given without steroids or chemotherapy like lymphodepletion that's needed for CAR T-cell therapy. And finally, this agent actually does not depend on T-cell health. So some of our later line patients who may have actually very low lymphocytes, these patients are expected still to respond. We have approval of our first CAR T-cell therapy, and we're all very excited about this. So idacaptogene vanclocel, or ide-cel. In general, I would prefer to use a BCMA targeted CAR T-cell therapy for younger patients or the more fit patients, those who really can travel to the specialty center to receive CAR. And there's about 70 centers across the US that will be FACT approved to give these CAR T-cell therapies. The patient has to have proper social support and also good reserve to tolerate the side effects, which include cytokine release syndrome. And with ide-cel occurring about 90% of patients, albeit most of it is grade 1 to 2, and only about 6% being grade 3 or 4, and possibly neurotoxicity, again, occurring in about 20% of patients, and grade 3 about 6% of patients. An obvious distinct disadvantage of CAR T-cell therapy is that it requires a hospital stay, a 2-week hospital stay, and also 2 weeks at the local center. And so some patients won't be able to do that. Now, a distinct advantage for CAR T-cell therapy is really this one and done phenomenon, meaning after they get their CAR T cells infused, patients are observed at the current time without any maintenance post-CAR. I saw a patient 2 to 3 weeks ago who came for her third year after her ide-cel therapy for her bone marrow biopsy, which was MRD negative at year 3, and she hasn't been on therapy for 3 years. This woman is having an amazing quality of life at the current time. And so that time off therapy is really quality of life for patients, which is nice. The also distinct, disadvantage of CAR T-cell therapy is patients who have rapid progression or very aggressive disease. They often can't wait for us to harvest T cells to transduce them with the CAR gene, and they can't really wait through manufacturing and then for them to be reinfused. They progress and they're not eligible, and that's unfortunate. Now, we are now starting to study some off-the-shelf CAR T-cell therapies. These are allogeneic CAR T-cell therapy. Now, we're waiting for more data. The initial data maybe seems promising, but we need more data on these off-the-shelf allogeneic CARs. And then the last BCMA-targeted therapy that will be approved is bispecific T-cell engaging antibodies. And maybe we should expect approval sometime in early to mid 2022. So not that far off, actually. And there's many advantages to these therapeutics, especially that these are off-the-shelf products. And as presented at Virtual ASH, with over 5 or 6 different bispecifics presented, they have very potent single agent activity, some showing activity greater than 40%, some over 60%, and even some over 80% response rates as in single agent in the truly relapse refractory patient. It was really amazing, some of the responses we've seen. Now, the disadvantage of these is they do require initial hospital stay. They are associated with CRS, mild CRS, definitely less CRS than associated with CAR T-cell therapy, and typically mild neurotoxicities. They do have to be followed closely in the first few weeks of initiating therapy. After those first 3 weeks, then it can entirely be done as an outpatient. Now, the dosing is continuous. So unlike CAR, where it's one and done, these have to be given continuously. And some of these are given IV. They're now actually, a lot of them are transitioning to subcutaneous dosing, which is really nice. And some are currently given weekly and then less frequently. And then we have some that actually are starting off being given once every 3 weeks, which is actually quite convenient, as convenient as belantamab mafodotin. Now I'll move then to sequencing, and it's easy because we have no current data on sequencing. And so the proper sequence is really unclear. There's actually one publication from Adam Cohen and some people from the Memorial Group discussing 2 patients, one that received CAR followed by ADC and another one that received ADC followed by CAR, showing responses to the subsequent BCMA-targeted therapy. So it can happen. I think the take-home should be that patients probably will be able to respond to multiple BCMA therapies, especially when going from CAR to ADC or ADC to CAR. And that's because the ADC does not depend on T-cell health. The CAR and the bispecifics depend on T-cell health. Perhaps if patients don't respond to those, perhaps the T-cells are just not healthy enough for those therapies. But certainly the ADC depends on a toxin, and the others depend on T-cell health. So we can do that. Now, I will say that multiple trials now are allowing a separate cohort in these BCMA-targeted therapies that enroll patients who have had a prior BCMA-targeted therapy. Previously, they were excluded. Now they're being allowed. And we'll know literally in the next 6 to 12 months how well patients respond to these subsequent therapies. Now, the final and I think one of the most fun questions that people ask is, where will these agents eventually be incorporated into the myeloma treatment paradigm? And, it's really going to be fun to watch as these agents are incorporated into the myeloma treatment paradigm. In general, these therapies show very significant single agent activity, especially the CARs and especially the bispecific T-cell engagers. Now, specifically for CARs and bispecifics, we think they might actually work better in earlier lines of therapy because the T-cell health is going to be much better in those patients, and hopefully they'll have a more durable response. So there are many spaces where these agents can be evaluated and used, in my mind, including high-risk smoldering multiple myeloma as part of induction therapy for transplant-eligible patients to try to get them in a really deep response before transplant, or even in transplant-ineligible patients, again, to get the deepest response. And specifically for CARs, for consolidation or maintenance after induction therapy, it might be possible to replace autologous stem cell transplant. That instead of doing an autologous transplant, which is still our most toxic therapy, in my mind, more toxic than CAR T-cell therapy, it might be able to replace it. CAR Ts may be able to induce a deeper remission than autologous transplant. These drugs are certainly going to be used in early relapse. Belantamab mafodotin is being combined with a variety of different agents, with bortezomib, with pomalidomide, other PIs, other IMiDs, other new agents like CELMoDs will be combined with these drugs. And so I think in early relapse, these are going to have great success. 10 years from now, my hypothesis is patients are going to get a CELMoD with a bispecific, followed by a CAR, and on relapse, they're going to get the same immunotherapy type regimens targeting a different cell surface marker. So it's really quite an exciting time for myeloma and the therapies that we have available and will soon be available. So stay tuned. We have a lot more to learn.
Now we'll have Dr. Kumar discuss how and when to use the other newly approved drugs, selinexor and melflufen, in clinical practice. He will also discuss the use of venetoclax, which is currently being investigated in clinical trials.
Treatment of myeloma continues to evolve fairly rapidly with the introduction of several new drug classes, especially in the past few years. The outcome of patients who have become refractory to a monoclonal antibody and IMiD and a proteasome inhibitor, the so-called triple-class refractory patients, has been quite poor, and this is where the newly approved drugs can clearly play a role. In fact, the approval of these drugs have been based on their efficacy and safety in groups of patients who have been exposed to these earlier classes of drugs. We have this selinexor, which is a nuclear transport protein inhibitor that is an oral drug used in combination with dexamethasone, and more recently melflufen, which is an alkylating agent or a modification of melphalan that allows the drug or the prodrug to concentrate in the tumor cells and thus provide a more targeted approach for that alkylating agent. Now, how these drugs can be used in the clinical setting are driven by a variety of different factors. It depends on, obviously, the patient preference for an oral drug versus an IV drug. More importantly, it also depends on the type of toxicity profile we see with these drugs. Now, selinexor can be associated with significant thrombocytopenia as well as GI toxicity and also fatigue. So if somebody has significant GI problems to start with, baseline toxicity or toxicity related to prior therapy, maybe selinexor is not the ideal drug to use. And melflufen has been associated with significant hematological toxicity. So also patients who have significant or have borderline blood counts that are not driven by the disease itself, it may be challenging sometimes to use drugs like melflufen that has hematological toxicity. Now, obviously, there is a lot of overlapping toxicity as well. Other considerations, especially the patient preference with respect to the frequency of administration and visits to the hospital, should be taken into account when we use these drugs. Now, as with relapsed myeloma, the preference is to use many of these new drugs in combinations. However, the data on combinations are still lacking at this point, except for selinexor, where a phase 3 trial has been completed with selinexor in combination with bortezomib dexamethasone. There's data from smaller phase 2 studies that also shows that selinexor can be combined effectively with other standard of care agents like the monoclonal antibodies, the anti-CD38 targeted ones, or the next generation proteasome inhibitors like carfilzomib. So certainly use of selinexor, especially if you are thinking of using a combination approach, that may be the one that is most amenable based on the data that we have. Now, clearly there are other drugs that are available in the clinic outside of the clinical trial, though not approved for treatment of myeloma. One such drug is venetoclax, which has shown significant activity in patients with translocation 11-14, something that is found in 15 to 20% of patients with myeloma. What we have seen in the single-arm studies is that venetoclax used in dexamethasone can provide response in up to 2/3 of patients with a translocation 11-14 and has relapsed myeloma. Now, it has also been studied in phase 3 trials in combination with bortezomib and in phase 2 trials in combination with carfilzomib or with daratumumab. In the phase 3 trial, the combination with bortezomib showed an increased mortality in patients with high-risk multiple myeloma, especially those with high-risk translocations like 414. So the use of venetoclax dexamethasone currently as an off-label approach should be limited to patients with a translocation 11-14, and even in that setting, consideration should be given to use of antibiotic prophylaxis to prevent any increased risk of infection, as was seen in the phase 3 trial setting with the BCMA trial. And there are several other new drugs that are coming through clinical trials, including some newer versions of immunomodulatory drugs called CellMods, and others. Obviously, their role in treatment of myeloma will continue to be defined over the next few years as we have data from different clinical trials.
Thank you very much, Dr. Kumar, Dr. Martin, Professor Moreau, Dr. Rajkumar, and Professor San-Miguel. And thanks to you, the listeners, for joining us. As a reminder, to view the full program, Accelerating Toward Curing Myeloma, Emerging Data, New Agents, and an Evolving Treatment Paradigm, please click on the link in the show notes. As always, thanks for listening.